Good morning, everyone. I'm Ihab Farag from Cleveland Clinic, and our talk about the point-of-care ultrasound or POCUS for upper airway management. So, I'm just for my conflict of interest. That my only conflict of interest that I am getting the royalties from Elsevier because I'm the editor of the Brown's Atlas of Regional Anesthesia, and also I got the honorarium from McMahon for writing some articles for them. That is the whole conflict of interest that I have. So for the objective for this session are very simple. We have to learn the importance of the POCUS for upper airway management and understand the different views for point of care for upper airway, also explain the point of predicting the difficult intubation, also illustrating the point of care confirming the ED tube and upper airway blocks and diagnosis of pneumothorax, also evaluating the point of care gastric ultrasound to provide bedside detailed quantitative and qualitative insight to gastric contents. All of that relating to the upper airway management by POCUS. So, why it is important? Because management of upper airway is a crucial skill. And inadequate management, of course, can lead to major morbidity and mortality. And actually, the ultrasound has gained importance as an effective bedside tool for upper airway management. So in order to understand how you can do the POCUS for the upper airway, you have to understand there are very simple views you can go through to full evaluation of the upper airway. The suprahyoid view, which is very important for oral space assessment, thyrohyoid for important of the assessment of the epiglottis, thyroid to assess the vocal cord, and the cricothyroid to assess the cricothyroid membrane identification, and supraesternal to look at the ET tube conformation. So let us go view by view. Suprahyoid view, we have to put the curved probe, place in the coronal plane, just posterior to the mentum, move posterior a little bit to view the hyoid bone, and then the view will visualize the floor of the mouth, the muscles of the tongue, and any pathological condition. Also, you can measure the width of the tongue and can be measured using Doppler to localize the two lingual arteries as they enter the tongue at its lateral borders. Every single part here is very important. Later, we can explain how it is clinically relevant. Now you can see the curved probe in the coronal plane. I can identify the tongue here and the hard palate, and here you can see the myelohyoid muscle and the genohyoid muscle, the genoglossus muscle, and the submandibular gland. If you put a both Doppler here, you can identify the two lingual arteries. And here the mandible, and this is the hard palate. That is in the transverse view. Also, you can do in the sagittal view. In the sagittal view, you can see the myelohyoid and the genohyoid muscle are visible as a linear hypoechoic bands extending between the mandible and the hyoid bone. Genoglossus and the geno and hypoglossal muscles lie deep to the genohyoid muscle and can be seen running like a fan-like fashion toward the dorsal surface of the tongue. And hard palate appears as a curvy linear hyperechoic line. Hyoid bone can be also seen in that view, and I'm going to show you here. You have here in the long axis, you can see the hyoid bone, and you can see the mandible, and you see the myelohyoid, genohyoid, genoglossus muscle, hypoglossal muscle, the hard palate, and the soft palate. You can also, if they let the patient to swallow a little bit of water, you can push the tongue a little bit and you can get better visualization of the hard palate and the soft palate and also the hyoid bone and the mandible. when I do the workshop for that, it is very easy view can be seen, and no one failed to get these views. How about the thyrohyoid? The thyrohyoid view, it is very important because in the thyrohyoid view, you can visualize the thyrohyoid membrane, and it is very important for the blocks, for the superior-laryngeal nerve block, and also you can visualize the epiglottis, and this is very important as well. So main structures in this view are strap muscles, thyrohyoid membrane, pre-epiglottic space, and the epiglottis. Thyroid and the cricoid cartilage show variable but progressive calcification through the lifespan can make visualizing the thyroid and the cricoid cartilage a little bit difficult. However, the only cartilage that's not calcified in the whole body is the epiglottis, because that can keep the epiglottis is movable to prevent aspiration. God created like that. It is very important feature that the epiglottis is the only cartilage that never and will never be calcified in the whole life. The thyroid membrane provides sonographic window through which the epiglottis can be visualized with the linear transducer in the transverse view or short ax view of the epiglottis. Also, the thyrohyoid view in the transverse view, the strap muscles converge medially and bridge over the hyperechoic thyrohyoid membrane. Deep to the thyrohyoid membrane is the hyperechoic epiglottic space, which contain epiglottic fat. Epiglottis appear as a hypoechoic structure. Deep to epiglottis, we have the hyperechoic line, which is the air mucosal interface of the laryngeal muscle. Long ax view, the thyrohyoid membrane also can be visualized as the hypoechoic line between the hyoid bone and the thyroid cartilage, and posterior to the thyrohyoid membrane, hyperechoic, of course, we saw the hyperechoic periepiglottic fat. And here we go. We have here in the transverse, we have the strap muscle, sternocleidomastoid muscle. This is the thyrohyoid membrane. Here the epiglottis, and here the epiglottic phase. It is hyperechoic. Epiglottis is hypoechoic, and deep to the epiglottis is the hyperechoic line, which mucosal air interface. The distance from the skin to the epiglottis is 0.89 centimeter. Remember that because it is very important. Later we can speak about its significance from the distance from the skin to epiglottis. Here in the long ax, you can see that you can put it in the long ax. You have the thyroid cartilage, hyoid bone, thyrohyoid membrane, epiglottic fat. It is hyperechoic, and the epiglottis. Here another area, you can hear the thyrohyoid membrane, you have here the hyoid bone, you have the thyroid, epiglottic fat, and this is the deep line beneath the epiglottis, and the epiglottis here hypoechoic. How about the thyroid view? Thyroid view is located over the thyroid cartilage, and it is used to visualize the vocal cords, and this is very important. Many structures can be viewed. The thyroid view is best seen in the short ax of the transverse view of the upper neck, while the neck is slightly extended. Thyroid cartilage appear as inverted V wave or a V-shaped structure. When the thyroid cartilage is hypoechoic in the short ax, the laryngeal structure can be very easily seen. Calcified thyroid cartilage with age, the vocal cords can still be seen by scanning up a little bit and tilting the probe so you can look at the arytenoid and the vocal cords. You have here put the probe in the transverse X of the thyroid cartilage, and you can visualize the vocal cords and the arytenoid cartilage very easily, and you have here the thyroid cartilage as inverted V-shaped. It is very, very easily to be viewed. Just put the linear probe in any patient, and you can see these structures. Also, we have here another view, and you have the vocal cords and the thyroid cartilage, and thyroid cartilage inverted here, and the strap muscle, And you have here the vocal cords and arytenoid. It's very easy and very simple view to be visualized. How about the cricothyroid view? Cricothyroid view, it is very important to visualize the cricothyroid membrane, and this is very important for cricothyroidotomy. The main structure in this view include cricoid cartilage, cricothyroid membrane, thyroid cartilage. Short ax view, where the linear transducer is placed initially at the level of the thyroid cartilage and slid inferiorly. The cricothyroid membrane appears as an echogenic linear structure demarcating the air mucosal interface of the trachea. Long ax view, probe is placed at the level of the thyroid and the cricoid cartilage. The CTM appears as hypoechoic structure anterior to the hyperechoic AM interface, and the cricoid cartilage appears as hypoechoic appearance in the long ax view as an arch-like structure or cuboid structure. And we can see that. You can here, you see the thyroid cartilage, you see the cricoid cartilage, and you see the cricothyroid membrane here, and you have to put just the probe in the long ax between the thyroid and the cricoid, and you can visualize the cricothyroid membrane. It is hypoechoic, but the air tissue interface, it is hyperechoic beneath it, so it can see that's the line. And here in the short ax, you can look at the sternocleidomastoid muscle. This is the cricothyroid membrane and the tissue interface. How about the trachea itself? And also this can show you that cricoid and the cricothyroid membrane in between the thyroid cartilage and the cricoid cartilage. Cricoid cartilage usually appears as a cuboid. So how about the trachea? The cricoid cartilage appear as hypoechoic rounded that serves as a reference point for long ax. Trachea rings are hypoechoic and they resemble a string of beads in the long ax view. In the short ax view, they resemble an inverted U shaped, highlighted by hyperechoic AM interface and the reverberation artifact posteriorly. And here, you have here the tracheal, this cricothyroid membrane, and here the cricoid, and it's a cuboid shape, and here the tracheal ring. And beneath it, of course, there is an air phase interface, which is hyperechoic line. And here, also, you have the air tissue interface, and you have seen the cricoid cartilage here, and this is the tracheal ring as a pair of strings in this long ax. Here in the short ax, you have sternocleidomastoid, and you have air tissue interface, and the tracheal ring is like inverted U-shaped. So how we can use all of this information for our clinical applications? Number one, for clinical applications, prediction of difficult laryngoscopy. Upper airway management carries a risk of complications. The emergent airway in the emergency department has 12% incidence of complications such as esophageal intubation, mainstream intubation, hypotension, cardiac arrest. Malampati score is only 51 to 53 sensitive to predicting difficult laryngoscopy and 17% sensitive for predicting difficult back-to-valve mask ventilation. POCUS is a good non-invasive imaging tool for airway assessment in both anesthesia and emergent department settings. Number one, there are several measurements we can use for predicting the difficult airway using the POCUS. Number one is hypomental distance measured from the anterior border of the thyroid of the hyoid bone and the posterior to the mandibular mentum. Hypomental distance ratio is defined as the ratio between hypomental distance as hyperextended neck position to the hypomental distance in the neutral position, and it's called R1, hypomental distance ratio 2. Hypomental distance ratio reflects the occipito-atlantoaxial complex extension capacity, and HMDR is predictive for difficult laryngoscopy. They found that HMDR cutoff of 1.2 discriminate between patients with easy versus difficult airways laryngoscopy. Wu et al. Found that HMD, hypomental distance less than 5.29 centimeter, has sensitivity of 96.7% and specificity of 71.6 for Cormick-Lehan grade more than 3. That means that you cannot see except the part of the epiglottis. They found that the shorter hypomental distance ratio of 1 to 1.05 in morbidly obese patients was found to high sensitivity for difficult laryngoscopy. Also, there is a very important marker or diameter that you can use, which is the distance from the skin to epiglottis, has the most data supporting its prediction for difficult laryngoscopy. DSE is evaluated in the thyrohyoid view with the probe in the transverse position. DSE reflects thickness of the pre-epiglottic space. DSE in a sniffing position of more or equal 2.48 centimeter was the best preoperative predictor of the Cormick-Lehan grade more than or equal to B, with sensitivity of 91.3 and a specificity of 96.9%. Also, the DSE in neutral position found that DSE of more than 2.54 centimeter was the best predictor of Cormick-Lehan of 2B, with sensitivity of 82% and a specificity of 91%. Oh. How I can get it back? Can someone call the outside? Oh, yeah, okay, we got it. All right, so if you are measuring the distance from the skin to epiglottis here, that is a predicted of the either easy intubation or difficult intubation. Here, the distance from the skin to epiglottis is 0.89 centimeter. Here is a difficult intubation patient, it is 2.7 centimeter. Because difficult intubation, or we say the high larynx, it actually is misnomer. It is a deep epiglottis, and we say high larynx because we are lifted by the laryngoscope higher to get it in our view. It is deep epiglottis, and that is the reason that it is difficult intubation. And here also, that's the difference between an easy intubation patient with 1.6 centimeter distance from the skin to epiglottis to here to difficult intubation patient from the skin to the epiglottis of 3 centimeter. It is deep epiglottis. So when you have a deep epiglottis, you need to lift it very high, the laryngoscope, to get it in view. So the POCUS is very helpful for predicting the difficult intubation. Also, the tongue thickness is very important for prediction of difficult intubation. They found that tongue thickness of more than 6.1 centimeter measure using the submental, as you see that we measure the tongue thickness in the coronal view of the suprahyoid view. The larger tongue thickness to the cyromental distance ratio greater than 0.87 can predict the tracheal or difficult tracheal intubation. Also, recent meta-analysis found the combination of these parameters in the extended and neutral ratio are the most associated with difficult laryngoscopy. However, we don't know about prediction of difficult mask ventilation. That algorithm can explain to you or summarize to you everything we have talking about how to predict the difficult intubation. For example, if you go for the cyrohyoid view to measure the distance from the skin to epiglottis, if it is more than 2.54 centimeter, yes, it can predicting difficult intubation. If you go for the suprahyoid view to measure the hypomental distance ratio in the neutral position, if the distance between the mentum and the hyoid bone is less than 5.2 centimeter, yes, it can predict difficult intubation. If you have the tongue thickness more than 6.1, yes, it can. If no, if you don't have that, you can go for the hypomental distance ratio when the head extended between the neutral and head extended hypomental distance ratio. If it's less than 1.8 centimeter, 1.8 ratio, yes, it can difficult intubation. If you measuring also the hypomental distance ratio between the head in the neutral position and head under pillow, if it is less than 1.2, yes, it can predict difficult intubation. And if no, that means that you have a normal airway predicted. So if you can combine that, you can give you a very good view how you can predict difficult intubation using ultrasound. Yes, it seems a little bit difficult or to measure it in the same time, but I think the best way for predicting the difficult intubation, I think according to literature, is the distance between the skin and epiglottis and also the hypomental distance ratio. That is the most, I think, most sensitive and most specific rather than going through all of these algorithms. But this, if you would like, have time and you do all of these algorithms or all of these measurements pre-operative, you can have a very good understanding how you predict the difficult intubation for the patient. How about the tracheal tube conformation? Capnography is less reliable in patients following bag valve mask use or recent ingestion of carbonated beverage due to increased carbon dioxide in the stomach and the esophagus. Less carbon dioxide is produced in patients suffering from pulmonary embolism, cardiac arrest, significant pulmonary edema, or severe bronchospasm. Also, the quantitative waveform capnography is only 60% to 68% sensitive for endotracheal intubation during cardiac arrest. The transtracheal ultrasound is 98.7 sensitive and 97.1 specific in adults for endotracheal conformation. Tracheal ultrasound has been induced in the recent AHA, American Heart Association guidelines, as the method to assess endotracheal placement after intubation. Transtracheal ultrasound is 92 to 100% sensitive and 100% specific in pediatric patients. If you would like, how you can do that, put the linear transducer placed transversely across the suprasternal notch to reveal the air-filled structure with acoustic shadowing. Successful endotracheal intubation yields what we call a single air-filled structure. Failed endotracheal tube produces two air-filled structure revealed a double track sign. Double track sign can be assessed, also can be missed in cases when the esophagus is located directly posterior to the trachea, as noted in as many as 16% of patients. Double track sign could also be used to confirm the presence of nasogastric tube. We have here the esophagus here and the trachea. The esophagus is potential space. So under ultrasound, it does not, if the trachea has the endotracheal tube, the esophagus does not appear like that. But if you have the endotracheal tube in the esophagus, is going to be a double track sign. So because the esophagus here is going to be filled. And here is the patient has a single track, the esophagus is disappear. So here it is false intubation. Here it is the normal intubation. This is a single track, here is the double track. Also, you can use the double track if you would like. You put the nasogastric tube for the patient, and you can use it to assess the position of the nasogastric tube. It is an esophagus or not, or curled or not. So it could use also for the harmful or for the benefit of the patient to assess the presence of the nasogastric tube after intubation. So it could be assessed for the false intubation, also for assist of the nasogastric tube. POCUS also can be used to assess the proper depth of endotracheal tube to avoid endotracheal intubation by visualizing the 880T cuff balloon at the level of the sternal notch in the long axis view. POCUS also can be used to confirm bilateral ventilation of both lungs by the presence of bilateral sliding of the visceral pleura against the parietal pleura during ventilation using B mode or M mode. If you put the ultrasound, you can see the bilateral sliding, so this means that the tube is in the proper position and you are ventilating both lungs. If you have one lung ventilation, that means that you got endotracheal tube, you find one lung is ventilated, the other lung is not ventilated. How about the diameter of the endotracheal tube as well? If you would like to use it to detect the diameter of endotracheal tube. POCUS is very helpful measuring diameter of the subglottic upper airway at the lower border of the cricoid cartilage and transverse view. POCUS measurement correlates well with MRI scan, the gold standard for measuring of the endotracheal tube or for the tracheal diameter. Also can be used for the measuring of the left main bronchus diameter. The left main bronchus for the one lung ventilation. Left main bronchus, the proper size of the left-sided double lumen can be measured also by POCUS. Outer diameter of the trachea is measured just above the sternoclavicular joint in the transverse view. Put the probe here, measure the transverse diameter of the trachea. They found the ratio between the left main bronchus and the outer diameter in the CT scan, and outer diameter also measured by ultrasound is 0.68. So if you put the probe in the over the sternoclavicular joint, you measure the transverse diameter of the trachea, that the left main bronchus is 0.68 of that, so you can give you a good prediction what is the left, how you can use the proper double lumen tube for the patient. Here, you can measure it, the transverse diameter of the, you can measure it here, the transverse diameter of the trachea, just below the cricoid cartilage. Put the ultrasound probe in the transverse and measure it just below the cricoid cartilage, can give you the idea about the measurement of the internal diameter of the tube. How about you can predicting the post-extubation stridor and airway edema? Cuff leak test is usually performed by deflating the endotracheal tube, followed by either listening to an audible air leak or looking for the difference between inspired or exhaled volumes of air, of course. POCUS can measurement with the difference of the air what we call air column width at the level of the vocal cords in the transverse view of the thyroid cartilage, before and after endotracheal cuff deflation was used to predict the post-extubation stridor. So they found that in both thyroidectomy patients, the ACWD and cuff leak was compared and found that high negative predictive value of 99.44 for a stridor. In the children, in 400 intubated children, ACWD of less than 0.8 millimeter had sensitivity of the 93% and specificity of 86%, of accuracy of the 91% of predicting post-extubation stridor, as compared to cuff leak test that had sensitivity of only 61 and specificity of 53. Air column width before extubation and after intubation ratio less than 0.86 is optimum cutoff to detect post-extubation stridor. Here, as you see that where air column width with the cuff up, 0.97, and after deflation 0.72, so the difference is less than 0.8. So that is good. That is good. That is good to prediction that this patient most probably will not develop post-stridor, post-extubation stridor. Also, the POCUS can be used for the obstructive sleep apnea, with width of the tongue base measured in the transverse view by the POCUS correlates with the severity of the related breathing disorder, including a patient's sensation of the nocturnal choking. How about the blocks? We can use it also for doing blocks. The superior laryngeal nerve divides the hyoid bone into internal and external branches. Internal branch passes inferior to the greater horn of the hyoid bone and pierces the thyrohyoid membrane, provides sensory innervation to the mucous membranes of the larynx above the vocal cords, as well as at the base of the tongue and epiglottis. External branch provides motor supply to the cricothyroid muscle. High frequency linear, we can use that. Is placed over the midline to visualize the thyroid cartilage and the hyoid bone, and just moving a little bit laterally to visualize the thyrohyoid membrane, and go with a very fine needle and then injection about 1.5 to 2 mils of lidocaine. But after aspiration, there is no blood. Here you have the probe visualizing the thyroid, hyoid bone, and then you can move it just a little bit lateral. You are going to find the thyroid cartilage, hyoid bone, thyrohyoid membrane, use inline, out of plane, and the real time you can just go with the needle here, pierce the thyrohyoid membrane and just aspirate and injecting the local anesthetics here. It takes about less than 2 minutes to do the superior laryngeal nerve block. And here also, this can visualizing the thyroid cartilage, hyoid, and the thyrohyoid membrane. We're just injecting here beneath it. It can be blocked very easily. How about the cricothyroidotomy? We can use that either for the recurrent laryngeal nerve block or for cricothyroidotomy. Cricothyroidotomy is one of the core skills of upper airway management. Success rate of correctly identified the CTM landmark technique varies from 32 to 39% compared to accuracy. Average CTM dimensions are 8 millimeter by 11 millimeter. Cricothyroidotomy can be performed using a real-time ultrasound, of course. Put the high frequency transducer, place in the transverse short X on the patient's neck, just above the suprasternal notch, moving up to visualize the trachea, which is like inverted U-shaped, and then the transducers rotated 90 degrees, and then you move up to visualize the cricoid and the thyrohyoid membrane, the cricothyroid membrane, and go moving a little bit laterally and go in real time out of plane. You can pierce that, so that you can use it for cricothyroidotomy or recurrent laryngeal nerve block. And here you can see that, can visualizing for you, that is the cricoid, cuboid, and the tracheal rings, cricothyroid membrane, and the thyroid cartilage, and here, and you can move just a little bit lateral and go out of plane here in the real time. You can pierce that and you can get the cricothyroid, either to perform a cricothyroidotomy or recurrent laryngeal nerve block. Also, you have here the cricoid, the cricothyroid membrane, and the thyroid, and you can just pierce that and you can get it to do either cricothyroidotomy or recurrent laryngeal nerve in the real time, and also it is very safe for the patient, especially with the morbidly obese patients. All right. Also, you can use it for the vocal cord assessment. The transtracheal assessment of the real-time vocal cords movement is useful and reliable method after thyroid and the parathyroid surgeries. Linear transducer is placed in the transverse view anterior to the midpoint of the thyroid cartilage. True vocal cords are hypoechoic, but may be distinguished by the fine hyperechoic ligaments of their medial edges. False vocal cords and arytenoids are hyperechoic. Adduction and abduction can be seen in ultrasound. And we have here put the ultrasound in the transverse view over the thyroid cartilage. You can see the vocal cords, and you can ask the patient to vocal and say, ah, you can see these vocal cords moving in front of you in real time. Success rate of true vocal cord is reduced, of course, by the calcification of the thyroid cartilage. Prospective study of 529 patients scheduled for thyroid parathyroid surgery. Preoperative ultrasound was as successful as a screening tool to evaluate the vocal cord movement in 84% of the patient, allowing visualization of vocal cord abnormalities for the invasive flexible bronchoscopy. You can use that preoperative and after surgery to assist for the vocal cords after thyroid and the parathyroid surgeries. Also, we can use it for the pneumothorax. Ultrasound effective for chest radiography for finding the excluding pneumothorax. Ultrasound is even more sensitive than chest X-ray. It can establish pneumothorax that is invisible in chest X-ray by diagnosing but diagnosed by CT scan. Pneumothorax diagnosed by losing of the lung sliding and dynamic interaction of parietal and visceral pleura. Also, we can put the M mode. You confirm pneumothorax in addition to loss of a sliding sign. Presence of the lung sliding, the pattern of the M mode is known as seashore sign. Pneumothorax in M mode does not register any movement at the pleura as the extrapulmonary soft tissues remain as a still linear image. This pattern is called the stratosphere or barcode sign. Absence of sliding sign can use successful single lung ventilation in thoracic surgeries. You have here the patient with pneumothorax, absence of the sliding, and you have here the stratosphere or in M mode or the barcode. Here we have positive sliding, and you have here the seashore. This means in M mode, this means that you have a normal pleura and no pneumothorax. Also, we can use it for epiglottitis. Acute epiglottitis is a life-threatening disease. Ultrasound has an overall sensitivity of radiography of detecting epiglottis is 89.94%. Linear transducer is placed in the transverse short X view just above the thyroid cartilage. In this view, the epiglottis will have a face appearance. The two hypoechoic eyes are the sternohyoid and the omohyoid, and the mouth is the cross-section of the epiglottis. Epiglottis appears as hypoechoic structure, as we say, and behind it is hyperechoic. The thickness of epiglottis is usually measured in the middle of the hypoechoic structure. Normal mean epiglottic thickness is 0.239, with greater thickness in male than in females. Increase in thickness twice the normal should be raised suspicions of acute epiglottitis. You have here, you can measure that, and this is for the epiglottis. You can measure the thickness of the epiglottis. The width of epiglottis can give you an idea about its thickness. And here the patient with epiglottitis, you have seen that it is increased the thickness, almost double the normal. After treatment with antibiotic, the thickness is reduced and becomes normal, and you see the epiglottis here. I'm going to show you a video to summarize
ultrasound-guided airway blocks, sonography and techniques. The axial ultrasound assessment of the airway begins with the patient in a supine position, with the neck slightly extended to optimize visualization. A high-frequency linear transducer is typically used. In an axial ultrasound view, the trachea appears as a round or oval hypoechoic structure in the midline of the anterior neck, with the cartilaginous rings forming anterior arcs that produce posterior acoustic shadowing. The anterior tracheal wall shows a bright echogenic line due to the air mucosa interface. Superficial to the trachea, the infrahyoid strap muscles and the thyroid isthmus may be visible. As we move cranially, the cricoid cartilage appears on ultrasound as a complete round or oval hypoechoic ring located just below the thyroid cartilage. Unlike the C-shaped tracheal rings, the cricoid forms a full circle, making it a key anatomical landmark. It has a characteristic inverted U shape in axial view. Just above the cricoid cartilage, we find the cricothyroid membrane, a thin hypoechoic band stretching between the lower border of the thyroid cartilage and the upper border of the cricoid. On ultrasound, it appears as a subtle dark line in the midline, bordered by the bright anterior cartilaginous structures. The thyroid cartilage is the largest laryngeal cartilage and sits just above the cricothyroid membrane. On axial ultrasound, it appears as a V-shaped or angular hypoechoic structure, more prominent in males due to the sharper angle. It forms the anterior wall of the larynx and serves as an important reference point for identifying the vocal cords and surrounding landmarks. The preepiglottic fat appears as a hyperechoic bright area anterior to the epiglottis and covered by the thyrohyoid membrane. At the most cranial level of the airway scan, the hyoid bone appears as a highly echogenic curved linear structure with strong posterior acoustic shadowing. In the sagittal ultrasound view, the transducer is placed longitudinally along the midline of the anterior neck. In this view, the cricoid cartilage appears as a hypoechoic bump, while the tracheal rings may appear as a row of hypoechoic rounded structures resembling a string of pearls. A bright linear hyperechoic line seen posteriorly corresponds to reverberation artifacts caused by the air mucosa interface. The cricothyroid membrane appears as a shallow depression located between the lower margin of the thyroid cartilage and the upper border of the cricoid cartilage. When the thyroid cartilage is not calcified, it appears as an oval-shaped hypoechoic structure with reverberation artifacts behind it. Sliding the probe cranially, the thyrohyoid membrane can be visualized between the thyroid cartilage and the hyoid bone, with preepiglottic fat seen just below it. The hyoid bone appears as a small, bright, echogenic structure with strong posterior acoustic shadowing, helping to define the upper border of the airway. Ultrasound visualization of the glossopharyngeal nerve is challenging due to its small size and deep location. It typically courses between the internal carotid artery and internal jugular vein just below the skull base, deep to the styloid process. Using a low-frequency convex array transducer, the scan is performed with the patient in a supine position and the head rotated slightly to the opposite side. The probe is placed transversely between the angle of the mandible and mastoid, moving the transducer posterior-inferiorly to visualize the carotid space. The nerve typically lies between the internal carotid artery and the internal jugular vein, posterior to the styloid process and deep to the digastric and stylohyoid muscles. Ultrasound-guided superior laryngeal nerve block. With the transducer in a sagittal orientation, we must first identify the hyoid bone as a curved, hyperechoic structure with posterior acoustic shadowing. The transducer is moved laterally until the preepiglottical fat is identified, located beneath the thyrohyoid muscle and membrane in a paramedian sagittal plane. Under real-time ultrasound guidance, insert a fine gauge needle, 25 to 27 gauge out of plane, from medial to lateral, targeting the space just deep to the thyrohyoid membrane. Once in position, aspirate to rule out vascular puncture and then inject 2 to 3 milliliters of local anesthetic. The spread should appear as a hypoechoic area separating the preepiglottic fat. Ultrasound-guided transtracheal injection is a reliable method to block the tracheal branches of the recurrent laryngeal nerve. This block is performed with the patient in a supine position and the neck extended. A high-frequency linear transducer is placed transversely over the anterior neck to identify the cricothyroid membrane between the thyroid and cricoid cartilages. The technique may be performed using anatomical landmarks with prior ultrasound mapping or under real-time ultrasound guidance. Under real-time ultrasound guidance, a fine needle is inserted in plane through the cricothyroid membrane into the tracheal lumen. Air aspiration confirms correct needle placement, followed by a rapid injection of 3 to 5 milliliters of 2% lidocaine. This typically elicits a reflex cough, which helps disperse the anesthetic over the tracheal mucosa and vocal cords. Ultrasound-guided glossopharyngeal nerve block. Begin by identifying the key anatomical landmarks under ultrasound. The glossopharyngeal nerve typically courses just medial and anterior to the styloid process near the lateral pharyngeal wall. Using an in-plane, posterior to anterior needle approach, insert a 22 to 25 gauge needle under real-time ultrasound guidance, advancing it toward the space just anterior to the styloid process and lateral to the pharyngeal wall. Avoid puncturing the nearby vascular structures by using color Doppler as needed. Once the needle tip is correctly positioned, aspirate to rule out intravascular placement, then inject 2 to 3 milliliters of local anesthetic.
So if you are recording that video, please use it for personal use because it's copyright, and don't disseminate it around, okay?
Ultrasound guide.
So the other important use of is gastric ultrasound as well. So the aspiration pneumonia among surgical patients is associated with 4-fold increased risk of intensive care admission, 90-day increase in length stay, and 7.6-fold increased risk of in-hospital mortality. Risk of aspiration can be increased in patients of delayed gastric emptying, such as those with diabetes, gastroesophageal reflux, morbid obesity, pregnant patient, or recent opioid use. Point of care gastric ultrasound provides the bedside detailed quantitative and qualitative insight into the gastric contents. Recently, with increased use of GLP-1, of course, receptor drugs for either treating diabetes or managing weight loss has increased risk of aspiration of gastric contents during general anesthesia due to delayed gastric emptying caused by those drugs. Gastric body has a greater air content that may interfere with the exam. Gastric fundus is difficult to access with ultrasound. However, gastric antrum appears to be the most valuable single location for gastric ultrasound to access the gastric contents. Antrum making the transition between the stomach's body and the pylorus and plays a crucial role in storing food before it passes through the pyloric sphincter into the duodenum. So the patient placed first in the supine position and then the right lateral cucubitus position to allow gravity to direct any gastric contents. Curvilinear, low frequencies placed in the parasagittal plane, just right to the midline, and probe orientation should be directed kephalad. In appropriate parasagittal view, the caudate and left loops of the liver and the superior mesenteric artery and the pancreas and the antrum and the aorta should be visualized very easily. The antrum should be visualized evaluated in both supine and right lateral decubitus position. Antrum is considered empty if it appears at a small bull's eye without an open lumen. The antrum is considered to contain food or drink. It appears to have endocavitary lumen and distended wall. The following ingestion of the food of solid air content mixed with solid bolus during forms a mucosal air interface along the anterior wall of the distended antrum. This large ring down air artifacts obscure the visualization of the posterior wall of the antrum, pancreas, and the aorta, and it is often called as a frosted glass pattern. And this is the frosted glass pattern. And I remember I was doing the workshop, and the model had just eaten, so I put the ultrasound, and I found that, and I told them, guys, I'm sorry, we cannot proceed. After the air is displaced, the antrum will appear distended with appropriate appreciable content of mixed echogenicity. You have here patient eating almost a solid food here. You have here the SMA, the pancreas, the antrum, the liver, and the aorta. Normal gastric secretion and clear fluids appear anechogenic or hypoechoic. Antrum becomes rounded, distended with thin walls as the volumes increases. As you see here, this clear fluid here. So immediately after fluid intake, gas bubbles can be seen as a small punctuate echoes called starry night appearance, usually disappear rapidly within minutes of ingestion. That is starry night appearance here, because you have air bubbles being absorbed. So how about the qualitative determination of the gastric contents using a simple 3-point system proposed by Berlas et al. For routine practice is the most helpful and useful bedside technique. The concern for aspiration risk is highest for grade 2 cases and somewhat reduced for grade 1. Stomach is considered full in the presence of any amount of solid or particular content. So if you have the antrum empty, that's grade 0, empty in both supine and lateral decubitus, grade 0. Minimal volume, it is less than 1.5 mils per kilogram, is detected only in the patient in the right lateral decubitus position. Antrum is visible distended with fluid in both supine and lateral decubitus. That means that the fluid is more than 1.5 mils. That means that this grade 2 and the patient is prone to high aspiration. So that is the qualitative technique. How about the quantitative technique? The volume of stomach contents in millimeters can be estimated by measuring the cross-sectional area of the antrum at the level of the aorta using the following equation: 27 plus 14.6 multiply cross-sectional area minus 1.28 multiply age. Pregnant women, they found that the cross-sectional area of 9.6 in the semi-recumbent lateral position can discriminate of low from the high gastric volume, and with a sensitivity in 80% and a specificity of 66%, an area under the curve is 0.28. There is a simple method as well for qualitative, that you can measure the cross-sectional area and go for this graph and put the cross-sectional area for the age. As long as it is in green, that means that you are safe. If not green, that means that you are having a high risk of aspiration. This is also a very simple by the qualitative exam. If you have empty, that means that grade 0, low risk. If you have clear fluid, what is the volume? If it is grade 1, it is less than 1.5, that means low risk. If it is higher than 1.5, that means that higher risk. If you have solid or high, that's immediately going for the high risk. I made that graph for you. So if you have a full stomach by gastric ultrasound, and you look at the POCUS and you find that the patient had high risk to be difficult intubation, use awake fiber optic intubation, delay the surgery, do whatever you would like in order to secure the upper airway safely. If you use the POCUS and you have the low probability for difficult intubation, you can go safely to rapid sequence induction, either direct laryngoscopy or video laryngoscope, the techniques that you prefer. So the conclusion that ultrasound has many advantages for imaging the airway. It is safe, quick, and repeatable, and gives a real-time dynamic images relevant to several aspects of airway management. Thank you very much.